Okay. So good morning, everyone. Welcome to the second case transmission in the CAFAB 2 of the first affiliated hospital of Harvard Medical University. And my name is Li Jianqiang. I'm the moderator. And as usual, I have to introduce my colleagues first. And the first operator is Dr. Gong Yongtai. And Dr. Zhao Jiyi, Dr. Sun Danghui, and Dr. Wang Dingyu. They are going to assist Dr. Gong during this procedure. I know in the other CAFAB, I think they have shown a very, very interesting case. I hope here we are going to also please you with this case. And first, Dr. Zhao will give the general information of this patient to you guys. Dr. Zhao, you can start.
Yeah. Good morning, everyone. I'm Zhao Jiyi. Before the operation leaving broadcast, I would like to make a brief introduction about our patient first. This patient is a 67-year-old male whose shift complete is paroxysm dyspnea for 1 month. The main risk factor of his disease is smoking. His echocardiogram showed an ejection fraction of 17% with no wall motional abnormalities. The electrocardiogram show sinus rhythm and no T view, inverted, and ST segment depression. Next, this patient received a PCI for acute coronary syndrome 2 years ago. The prior coronary angiography showed that there was a subtotal occlusion in the right coronary artery with TME flow grade 0. There was a serious stenosis in the proximal LAD with severe calcification. There was an obvious stenosis in the outcome of the first diagonal branch. So this is a true bifurcation lesion. We also found over 70% stenosis, as well as severe calcification exists in the middle segment of the LCS. Next. We implanted 4 stents in RCA, and the final result tended to be satisfactory. Next. Due to the epidemic, the patient's complete revascularization was delayed after his discharge. Before the operation, we conduct QFR examination on the patient. The QFR of LAD was 0.28. Next. The QFR of ICS was 0.67. Next. Virtual standing technique simulates the effect of standing implantation in selected segments using predicted value of QFR. By using the QFR-based virtual standing technique, the QFR of LAD may be increased from 0.28 to 10. Next. The QFR of LCS may be increased from 0.67 to 1. It could help us to make a plan before the operation. Next. And then we have performed a CTA scan on the patient, and the results showed that there was a serious stenosis with severe calcification in the left main to the proximal LAD. The stents in RCA had good expansion. Next. In order to understand the coronary artery lesion deeply, the intelligent visualization system for CTA invited by Professor Li Yue in our hospital would help us to get more information. Please, Professor Wang Dingyu, introduce this part.
Thank you, Professor Zhao. Now I will introduce intelligent visualization system for coronary CT angiography, which is an original technique by Professor Li Yue. We have shown this system for several times in the previous cases. Now we have the aorta and its calcified plaques. We see the right coronary artery are with a full metal jacket stent, and we had the right coronary artery and its plaque and the stent, and enlarge the left coronary artery. In the image, we can see there are heavy calcification in LAD and the left main. We rotate the image. Okay, we see from the left main to the proximal LAD, there's a heavy calcification, and we rotate the vessel freely. We see in the proximal almost ostium of the LAD, there's there's a calcified plaque surrounding the LAD, which is more than 270 degree. These calcified plaques will influence the stent expansion exactly. So we should do something to debugging or modify the plaque. And also we can see there's heavy calcified plaques in the diagonal branch and the mid LAD, just like other heavy smokers. This patient is with heavy calcified plaques. That's all.
All right, thank you, Dr. Zhao. Thank you, Dr. Wang. So I think this is very complex lesion. This is multivessel lesion, and the right coronary artery was stand default. Right now, we could see severe stenosis in circumflex. We could also see very diffuse and severe stenosis in the proximal to the middle part of RED. And it's also a bifurcation because it involves the proximal parts of diagonal, and we could see severe calcification. So I think this is a very interesting case. So Dr. Gong, what's your strategy?
Okay, morning everyone. For this patient, they are very complex because of severe calcification and diffuse lesion and two-sided branch with severe stenosis. For this patient, of course, very important for the strategy selection and the procedure and the technique. For this patient, the circumflex is smaller, and the diagonal side branch is small, is much larger, and also has significant lesion. For this patient, after intravascular imaging, we found surface calcification, and we performed intravascular lithotripsy to modify the calcification, and then implanted 3 stents from the middle left anterior descending to the left main, and the diagonal and the circumflex were protected by gelled balloon. Now, after stenting, we will perform the kissing balloon inflation and the poster dilatation to get stent optimization and to protect the side branch.
All right, so can we show the audience the AVAS image before you put the stents?
Okay.
So can we show the AVAS of RED?
Dr. Wang?
As you mentioned, from the AVAS image, we could see lots of calcification in LED.
Okay. Professor Wang, can you tell us the finding of the IVAS?
Okay, just like the CT show us, we can see the AVAS image of LED. The digital part of the LED is almost healthy, but since the middle part of LED, there's heavy plaque, some soft plaques, but there's also, we can see from here, there is some calcified plaques. It's more than 90 degree, but we can okay. Now there are heavy soft plaques, and there's a cell branch here. Okay, this is the most severe calcification. Is about, it's just like circles around the LED lumen. We see it's almost 360 degree. And the mean diameter of the lumen is 1.84 millimeter and 2.76 millimeter.
Yeah, we could say, the most severe calcification is located in the proximal parts of LED, because the lumen, I think, is kind of big enough. That's why Dr. Gong choose FAL to pre-treat this calcified lesion. So I think we use maybe 6 or 7 circles of pulses. So, and then after that, we also perform the AVAS. So could you show us the AVAS after the use of FAL?
Okay.
IVL. Show you the
after the use of FAL.
After FAL. Okay. This is the AVAS image after the use of 3.0 shockwave balloon. Okay, just come to the proximal part of our AD. Okay, we can see the wire in the diagonal, and we see there are some fracture of the calcified plaques in the AVAS. This is a good example for the use of IVL.
Yeah, from the AVAS, I think we could see some fractures. That means the IVL did work. And actually, Dr. Gong, except for the IVL, Dr. Gong also used the cutting balloon to better pre-treat this lesion because the calcification is too severe. And after the pre-treatments, and Dr. Gong put 3 stents from the middle proximal to the left mean, right?
Yes.
Because there's a clear discrepancy in diameter between the left mean and the proximal parts of LED. That's why you choose 3 stents.
Yes. And another important is that we should perform gelled balloon technique respectively to protect the diagonal branch and the circumflex. So the instant implantation, the balloon should be positioned at the ostium of the side branch. In this setting, I think for this patient, the 3 stent is more suitable and a good selection.
Yeah, because I think I get your point. If you choose 2 stents and the second stent has to be very long, that may cover the ostium of the first diagonal and also the ostium of the circumflex. And then you have to protect both branches because you use a 7 French guiding catheter. if you try to protect two branches at the same time, that will make this procedure very complex. That's why I think it's better to put three stents, right?
Yes.
So one to protect one branch at one time.
Yes.
So what are you doing right now? Just get us very clear what I are doing right now.
With your troubles, we encounter troublesome for the occlusion of the diagonal because the although we have performed the gelled balloon protection, but unfortunately, the deflection from proximal LAD extended to the first diagonal, and we will try to rewire to the first diagonal and then perform PTCA to rescue the TIMI flow to get the better outcome.
So because there's a dissection at the ostrom of first diagonal, so right now you have to rewire the first diagonal. So you want, what's your next? Because you want to put it in another stance?
No. The diagonal has diffuse leaving and no good stent landing zone.
Mm-hmm.
It's very complex setting for we just I think need balloon plated.